Thank you very much for your very kind introduction. And as I did yesterday at the Technology Symposium, I would like to thank the Scientific and Organizing Committee for having invited me here. As mentioned, I've lived in Saudi Arabia for many years and always intended to come up to Kuwait and never did get the opportunity. So I'm very personally much appreciative of this. When I first started writing this talk, it was in a slightly different direction than what I'll be presenting today. When I looked at the type of talks that were coming afterwards, I thought it would be best for me to attempt to try and make this somewhat of an introduction to segue into the more detailed presentations that will come from the real experts and not me. As pointed out here, I'm from Amersham, this old Amersham, which has been there really since about 900 AD, and that's St. Mary's Church, which has been there since 1100 AD. So we'll start off with the past. And despite impressions, scintimammography is not necessarily that new modality. First publication that I could find anyways in my search did come out 40 years ago by Cancroft and Goldsmith. And they used protectitate scintigraphy as an aid in the diagnosis of breast masses anyways. And they claimed that it assisted the differential diagnosis for palpable masses or suspicious mammography. The method of action for protectitate was considered unknown, but it was thought that the uptake and retention was within the extracellular fluid space of solid masses surrounded by adipose tissue. Even at those early days, it was considered as a possible or potential screening modality, but eventually, obviously, it did lose out to X-ray mammography. A little later, MDP was investigated, and again, it was thought that the uptake was due to retention within the extracellular fluid space. However, there was the possibility of it being MDP, was that there was some possible attachment to microcalcifications. Now, before I go on further, I want to look at X-ray mammography and really why breast scintimammography is of interest. Now, this is some work that a colleague and I did a few years back at the King Fahd Hospital in Riyadh. Now, the graph at the top is showing what is really the big issue in any type of mammography. It's the balance between radiation dose and diagnostic efficacy. The breast is acutely sensitive to radiation for radiogenic cancers. Now, here in this graph, I'm showing the dose to the breast on the ordinate, the y-axis, and the contrast, which is a measure of image quality. Lower contrast means it's difficult to see microcalcifications, difficult to recognize any distortions in the parenchymal architecture. And each of the plots that you see there with the different dimensions of millimeters is the compressed breast thickness. You see here in this particular image, conventionally, in mammography, the breast has to be compressed to reduce scatter and to increase efficacy. Well, all of these plots show that the larger the breast is, the less contrast, the less diagnostic quality there is, but the radiation dose goes up. So that is why there's an interest in mammography, scintimammography. The next graph is a survey that we did do over a couple of years where we measured radiologically the breast thickness of women, some 300 women, as a function of age. Now, statistics aren't fantastic, but what you see is overall is this negative, sorry, I don't have a laser, but you can see a negative trend. What that's really reflecting is that there's adipose tissue is being replaced by, glandular tissue at a higher density is being replaced by adipose tissue at a lower density. Now, the European Association of Nuclear Medicine has procedure guidelines for tumor imaging and breast scintigraphy. Now, the first two could be potentially contentious, and this is the indications that there's a detection of breast cancer when X-ray mammography is doubtful, inadequate, or indeterminate. It's also complementary if there's doubtful microcalcifications or doubtful distortion in the parenchymal architecture. One could argue that a clinician say, well, if I have any doubt, I'm going to do a biopsy anyways. I'm not going to use scintimammography at all. So that is certainly a very strongly held point of view by many. It's also recognized as an indication for mammographically dense breast tissue or where there's a presence of scar tissue or in the case of breast implants. So the present. Currently, there are two modern agents used in scintimammography, CSNMMMI and tetraphosphamide, MIBI and MyoView. They're both cationic complexes of technetium, and they're markers of transmembrane electric potentials and concentrate within the mitochondria. In the next talk, Dr. Al-Rawali will be going into much more detail of the radiopharmaceuticals that are used in mammography. So this is just really just an introduction for what he will be presenting. Now, conventional gamma camera planar mammography is a bit difficult. This is done in the prone position. As you can see here, the intent is that using gravity, the breast is dependent. It separates the breast from the thorax because there's background activity within the thorax which could mask any lesions which have uptake within the breast itself. And you can see there faintly with that arrow that there's that indication there of an uptake by tumor. Here's another case of the dependent breast being compared to a conventional mammogram, and you can see the comparison is fairly self-evident. SPECT is also possible in this position. This is from a clinical trial that I did about 8 years ago for marocyclotide, which I'll be talking about later, and you can see the breast lesion there in this lady who's prone. Therapy monitoring is also a possibility. Here's an indication of over a period of time with a tumor, or at least the uptake, we should say, within the tumor, diminishing over time as a consequence of therapy. Comparison of MIBI and tetraphosphamide is rather difficult. The reason for that, for the indication of tumor imaging, MIBI is licensed in the US, but it's not licensed in Europe. And tetraphosphamide is licensed in Europe, but not licensed in the US. So the geography is working against us. I did find one paper, and this was a study that was done in Israel, so they had access to both MIBI and tetraphosphamide, and they did a head-to-head comparison between the two. And this was with 35 consecutive women with palpable mass or an abnormal mammogram. There was a 2-day separation between the tetraphosphamide image and the MIBI image. And then pathology was obtained by either needle or open biopsy 2 weeks later. And if we look at the diagnostic efficacy metrics, sensitivity, specificity, positive and negative predictive value, and accuracy, there's no difference. You would say there's absolutely no difference between the two agents in terms of their diagnostics. Other studies, obviously because of the different geographies of where these agents are available, have been done through meta-analyses, and they come up with the same conclusion. The diagnostic efficacy of MIBI and tetraphosphamide in breast scintimammography are the same. Now, there are problems with the conventional gamma camera. First off, it's obviously not designed for scintimammography. It's bulky. SPECT does not necessarily allow easy delineation of where the lesion is. But a lateral prone position would provide at least the view of the breast contour to assist. Key thing is, and this is where the physics comes in, is that the distance between the breast and the camera head reduces resolution. Another interesting possibility is that using a dual-headed camera is that both breasts can be imaged simultaneously, but that will require some degree of shielding between the breasts in order to avoid crosstalk. So it becomes a little bit more complicated. So the solution is to develop and use small breast imaging specific devices that allow direct contact with the breast to provide both higher spatial resolution and detection efficiency. This has the added advantage that it reduces the amount of administered activity and reduces the radiation dose to the patient. And I see a little later that Dr. Keeper will be going into much more detail about breast-specific gamma cameras, but I'll just go through some examples here. Now, this is an early prototype that was built on a converted conventional X-ray mammogram using a CZT detector, which I'll come to in a minute, with a 20 by 20 centimeter squared field of view. You can see there's a compression plate. Now, compression plate in conventional X-ray mammography compresses the breast considerably, but it's only for a short period of time. With scintimammography, where one has to obtain the number of counts, breast compression becomes an issue, and the breast cannot be compressed as much because obviously the patient's discomfort. Now, CZT is cadmium zinc telluride. It's a solid-state detector. It was originally developed in the early 1970s, late 1960s for space-based radiation detection. It's being a solid-state semiconductor. It's constructed from ingots. and requires high purification. Hence, it is extremely expensive, and there's only a small number of manufacturers throughout the world. Last I heard there was 5. I think GE bought 1, so that makes it 4. They can form pixelated detectors. Now, it has a high atomic number compared to sodium iodide, a conventional sodium iodide crystal used in a gamma camera, so that increases detection efficiency. Solid state has a high detection efficiency, and that also leads to high energy resolution, so we can reduce the amount of scatter contributions. However, the expense of CZT is limited to commercial applications to small fields of view detectors, primarily scintimammography and cardiac imaging devices. This shows the module for CZT. The module itself here is on the left, and that contains, it's 4 by 4 centimeters and contains 16 by 16 pixels. And that then could be mounted in with a whole series of these modules to form a 20 by 20 centimeter modular field of view. And if you look at the fact you actually have detectors going right up to the edge of the module, you are avoiding the edge effect that one sees in conventional gamma cameras. And these show 2 commercial units, the Gamma Medica LumaGem and the GE Healthcare NM750B. And you can see both cases, they've added a second head where the compression plate in the conventional X-ray mammography has been replaced by another CZT detector. And that increases the efficiency of detection. Again, with the implicit sort of direction, as it were, that having increased your efficiency, one can then decrease the amount of administered activity. Now, new diagnostic radiopharmaceuticals are coming about. This is one that I've been working on actually for about 10 years. It's technetium-labeled maracyclotide. It's a peptide, RGD compound, targets the alpha V beta 3/5 integrins, which express in tumor cells and in the epithelium during angiogenesis. And we have been investigating this as a tumor imaging agent, including breast tumors. Now, angiogenesis is really a series of events, and just as an introduction to it, one has the AGF, the angiogenic growth factor, released by a tumor, which then binds to the endothelial cell receptors. These become activated and releasing enzymes which dissolve the basement membrane, and then these migrate through these integrins towards the tumor, and eventually the tumor then becomes vasculated. One of the reasons that we're looking at, have been looking at, not only us, but several other investigators at angiogenic imaging agents, is that there are anti-angiogenic agent drugs out. The problem with them is they don't work for everybody, and they're very expensive. So if one can come up with a tracer that can indicate that this particular patient will or will not respond to an anti-angiogenic, such as agent, then obviously there are some health economic advantages. Maracyclotide, this is its structure. It can be labeled, maracyclotide itself is labeled with technetium. We have a similar agent called flucyclotide, which has been in the literature, which is labeled by fluorine 18, and that's used for PET. And we published a number of papers looking at that in various clinical trials. But I'll be looking specifically at the study that we did with maracyclotide using technetium. We did a phase 2A study, proof of concept. It wasn't necessarily to be looking at detection of breast cancer or scintimammography. It was really, can this thing actually detect a tumor, which we know would be angiogenic? So primary CA breast was selected because there was the ease of post-imaging pathology. The pathology has to be after the imaging. The reason for that is that if you do the pathology before, if you do a biopsy, you'll have a wounding, you'll have healing, and that could cause an angiogenic signal, which could block out the signal that you're attempting to get from the tumor. And we've seen this in preclinical studies. So we decided this had to be done, the pathology had to be done after the imaging. 20 patients were recruited, 16 with a suggestive mammogram, 5 with what were considered to be benign lesions. And as a proof of concept, again, it's not attested as scintimammography. Lesions were expected to be greater than a centimeter, so we knew we would get some nature of a signal. This was a study that I personally felt would not work. I felt that if a woman had just been notified that she had a questionable mammogram, the last thing that she would want to do is have an imaging study that would not have any benefit for her. That's one of the things in developing diagnostic agents, is that one's relying upon the altruism of the patient. whereas in a therapeutic, the patient figures that there may be some advantage to them. I was proven quite wrong. We were amazed at the recruitment rate. In each case, 700 or so megabecquerels of myrocyclotide was administered, and the standard of choice was based upon histopathology, which was taken up to 2 weeks post-imaging. We did 2 natures of study conventionally on the gamma camera, as I showed earlier, the planar conventional prone supine spec, and the prototype breast-specific imaging unit that you saw earlier, and that was used in some cases. Now, this shows the examples from the results. It's published by Tori Bak-Gansmo. And we see, for example, in the first figure 1, where the woman is lying prone, this is lateral view, and we see an IDC, which was actually less than a centimeter, it's 8 millimeters. Figure 3 is, it's a planar, straight, and we see a fairly large lesion, and also we see uptake in one of the lymph nodes. The last image over here is that taken on the Lumagem prototype mammography, scintimammography unit, breast-specific imaging agent, as you see there, and certainly lesions are detected there. Now, one of the issues, and this is obviously something that I'm as a medical physicist with a special interest in radiation dosimetry, is what are the relative radiation doses to the patient? What are the relative risks? Because obviously at the end one has to make a risk versus benefit calculation, even if it is subconscious. Looking at the 3 agents, tetraphosphamide, MIBI, and myrocyclotide, we look at the effective dose for the 740 megabecquerel administered activity. Now, as a reminder, the effective dose is a weighted sum of radiation absorbed doses to specific organs. And the weighting factors reflect the particular radiation sensitivity to that particular organ, and that sensitivity is expressed in terms of carcinogenesis or hereditary effects. And we see they're more or less the same, between 5.2 and 6.3 millisievert. Just to give you a background, an annual background exposure that you get from natural radiation is about 2 to 3 millisieverts. So it's about 2 to perhaps 3 years of background radiation. So I don't think there's any particular great difference there, although one could perhaps argue that one is looking at a 20% difference between tetraphosphamide and MIBI. Now, the mean breast dose, there's a considerable difference, almost a factor of 3. This is in milligray. Now, if you remember that graph I showed earlier, in X-ray mammography, we would typically expect about a 2 to 3 milligray radiation dose to the breast, depending upon, obviously, the breast thickness. And the difference here, when we try to make a comparison, is that these are nuclear medicine calculations based upon one type of model of the breast, whereas the X-ray mammography calculations are based upon a more realistic and detailed model. So it's very difficult to translate this to what we see in X-ray mammography. But I think the key thing is that between tetraphosphamide and MIBI, we see a factor of 3 difference. The future, to line up here, it's going to be a very short slide. What are the possibilities? Well, positron emission mammography. Well, yes, people are doing it. Dr. Klinyak will be discussing that later this morning. And what I'm particularly interested in are in new targeted diagnostic radiopharmaceuticals, and particularly HER2. There are a number of investigators that are looking at that particular receptor in terms of therapies, in terms of HER2 positive or HER2 negative. Screening, despite there are some very vocal proponents, I just don't see it happening. Now, inclusion within the diagnostic algorithm. Now, that's the interesting question. If you recall back when I was referring to the EANM guidelines, those first 2 points, if one has a questionable mammogram, one would think the clinician would say, I'm not going to waste my time doing scintimammography. I'm going to do a biopsy and get the answer right now. But I did go back and investigate that, because that was certainly my opinion. But there was a study that was done. It was published in the American Journal of Surgery. Admittedly, this was a study done about 10, 12 years back, but I don't think the lessons there are necessarily irrelevant now. This is a multi-center trial recruiting over 1,700 women, and specifically the women with stage BI-RADS 3 or 4 with equivocal mammography underwent scintimammography, and this would be with MIBI. And they had sensitivity, specificity of 88% to 91%, and that's not something particularly to sniff at. But what I found was most interesting was that when scintimammography was introduced in the diagnostic algorithm, was that it reduced the number of unnecessary biopsies by 62% and reduced the number of missed cancers by 86%. So I still think the jury's out on that. I think that's something that we can't necessarily ignore. Questionable mammogram, immediately do a biopsy. But I think that is certainly some food for thought. So I'm hoping that this provides some nature of a segue into the next speakers, and I'd like to thank you very much for your attention.